All right, welcome back to the season finale. Yes, season finale of the Beyond the Scope podcast presented by MDMD Productions and made possible by Get Up Productions, your one-stop shop for launching your podcast. Let Get Up do the heavy lifting and give you the tools you need to turn your podcast dreams into a reality. Learn more at augustapodcast.com/ndmd. I'm your host, Andy, at the end of the third year of med school, and I am joined by two of the day one, Carter, David. David, you've been a familiar face to this show.
Glad to be back.
Carter, you finally get your...
What do you mean finally?
Finally, after...
I've not been begging to do this.
After like 2.5 years of begging to make an appearance on the channel, not in the context of your dog or saying something questionable in one of my vlogs. Hi, Carter.
Yep. Pleasure to be here.
He's also an Apex world champion.
I mean, I don't know about that, but you know, so the big news I was planning to drop today was that I hit D3 last night. So that means I'm in like the top about like 1% of the game, which I think fairly certainly probably cements me as the best Apex player in medical school.
I cannot confirm, but that's a pretty bold statement to make. If anybody would like to refute it, please find his Twitch channel. But anyways, we can tune into Carter's Twitch stream another day. But for the season finale of Beyond the Scope, we have all finished our third year of med school, which means we went through all of our core rotations, for better or worse. And so I figured, let's round off this year by ranking our core rotations. And I know we all had various different experiences in our rotations depending on the site we went to. And also at the time of us recording, well, if you're watching this now, Merry Christmas if you celebrate it. Happy holidays if you don't, because this will be going out on Christmas. But David, Carter, what rotations did we go through over the past year?
So Carter and I started out together on Psychiatry and Neurology. And then pretty early on, we both did OB, Pediatrics, Family Medicine, and then Internal Medicine and Surgery later down the road. And I think that hits them all.
And then we each got 2 elective blocks throughout the year. What did you guys do for your electives?
I did a respiratory care elective, and then I planned to study for step 1 and just said, actually, never mind. So I just took like 4 weeks to hang out.
Yeah, and I did a research elective for one of my blocks, and then for the other one was studying for medicine and surgery because those were my last 2 rotations after that.
Okay. And for me, I ended up doing a simulation education elective as well as an anesthesia elective. So those will kind of be bonus categories for us to rank. But if you see right here, we have the board ranking from S tier, and I don't know if you can see it, F tier is all the way down here. But we're going to try to break down our experiences over this past year. It's a lot to unpack, but we'll try to do it succinctly without endangering our careers.
I don't know why you looked at me when you said that.
Says the person that I've had to bleep out in most of my vlogs. I'm looking out for you, man.
Thanks, I guess.
No. Okay, so the reason why, obviously, I brought you guys both on is because some of the best and brightest of the students of our class. And so you guys probably killed your rotations and would have an objective reading of how to really navigate things.
I thought the only reason you brought us on was because we were the only ones who would take your money.
Guys, not here, not now. Come on, you'll get your check in the mail. All right, Merry Christmas. Anyways, all right. So, what order should we go down?
I mean,
I'll start us off. We're doing it the order that I did it because that's the only way I'll be able to think about it.
Okay.
All right, so we're starting with psych.
All
which,
right.
To start with, I'm going to say that was what me and David started with. We probably didn't appreciate it enough at the time, but, we had a very relaxed experience. So I would say our inpatient psych was definitely one of the best inpatient experiences I had, but I just didn't really know what was going on at the time because it was my first rotation. But psych is also where I learned that I absolutely hate outpatient. So I was not a big fan of outpatient clinic, and psych outpatient clinic is everything I hate about outpatient, like all rolled into one. So,
But like overall, so it was a 3-week rotation for us
Yeah.
all. There's a reason why they call it psychiation.
Yeah. So, like, hours-wise, very easy. Especially, like, where Carter and I were in particular is one of the easier in terms of hours sites. I agree with Carter. Like, anything you do first in your rotations, no matter what it is, you're not going to get out of what you would do later in the year just because of what you know and what you don't know. And especially the site we were at, there was limited involvement for the students. Like, everything was on paper charts still.
that's a plus in my book. So
Is
there
it?
was no documenting for us.
Yeah.
Yeah, we didn't
okay.
we didn't
Yeah.
write any notes until
Yes.
I had to do outpatient. Then I had to write notes.
The residents and fellows were really driving the ship, and I think in other situations where residents and fellows are entrusted with that much responsibility, they bring in the students a lot. But there's really limited engagement for students at this particular site, which made it like a little bit less of an enjoyable rotation.
Yeah. I mean, I still had to write notes because of where I was, and I was also at very much a state institution, so it was a little bit interesting. I think you get more of the like far end of the spectrum of pathology, which is still insane. Like you never forget the first time you see someone like talking to a corner and just like fully having a conversation.
Yeah.
But like, I mean, the hours were great. Stunning was pretty easy. The shelf wasn't terrible. Like, it was challenging because you had very little room for error. Doesn't it curve down?
On the shelf?
Yeah.
I mean, I think it's like the only one where like your grade I think it's like the only one that's like a 1-to-1 that I think you actually have to get an A to get like an A on the shelf.
Yeah.
I might be making stuff up, but
I mean, I would say enjoyable. I scheduled it kind of like as a break after what's it? I did mine after neuro, but it was after my medicine rotation, so I knew it was going to be a little bit chiller. So definitely one to schedule after a hard rotation, so you can give your mind a break.
Yeah, I think starting with it also made that tough because it set this standard for Carter and I'd be like, oh, what are people talking about? Like, rotations are so relaxed. This is wonderful.
Yeah.
And that quickly ended.
I think it was a nice little like gentle, warm hug to welcome me into rotations.
Yeah.
So where are we putting it
Ooh.
on the list? I'm going to go ahead and say, despite all the nice things everyone has said about inpatient and the nice hours and psychiation and all that, I hated the outpatient experience so much, I'm putting it in B tier.
I would have been happy to throw it in C tier.
I would be.
I'm fine with it.
I would put a vote for B tier just because it was. I think for those who are not interested in any procedural based stuff or really enjoy that outpatient setting, I think it's a very nice rotation. It's very relaxed. The residents all are not very like hardcore or intense. They'll teach you if you want, but if you want to be hands off, they'll be like, go home, have lunch. And for that, you get a lot of flexibility. So I would bump it to B tier.
I'm fine with
Can we
that.
go there? Alrighty.
Yeah. We'll say a low B.
So I'll write it like down here, like psych.
Yeah.
All right, a low B tier.
All right. So next after that was neuro, which was another one that I didn't. Me and David had different experiences. David was, I think, on the stroke team. I was just on like the general inpatient neuro team. And I will say that also I didn't appreciate how amazing my residents were at the time. I think that those were some of the best residents I had throughout like my whole time. Like they were like very understanding of like all the mess ups I made. They were always like watching my back and making sure that like I was ready for rounds and like ready for presentations and all that sort of stuff. And they were really patient with me. So I would say, and like what was also really nice was like I keep bumping into like the senior resident like in the hallways, and like she still remembers me and will like happily wave to me. So I think she's like one of the only residents that actually like still remembers me. So
they say more about you as a student than
very unmemorable. But so I would say I had amazing residents. I think the faculty were really invested in teaching, which I didn't really like fully appreciate at the time. But also neuro was half outpatient, half inpatient. So for that, I have to like dock it like a whole letter grade. So as far as like my inpatient experience, I think it was kind of repetitive. It was a lot of seizures, a lot of I'm trying to remember what else. Like there was like a few times we like got consulted on some nerve stuff.
Anisocoria.
I don't know what that word means, but
what's the whole like pseudo seizure one? The one that's like,
which is no longer a term anymore.
Yeah,
psychogenic non-epileptic seizure.
That's it. Yeah, I remember getting called in for a lot.
There was a lot of altered mental status, consults too. I remember that. There was one morning that, so I went to go check on a lady who we had been consulted because of altered mental status. Then I went and checked on her that morning. She was doing great. My leading hypothesis was that her altered mental status was because the medicine team had like dropped her blood pressure from like 180 over 110 to like 120 over 90 like overnight, and then like a matter of hours. So I was just like, you know what? It's probably just the brain not getting enough blood. She looks great this morning. We can probably sign off, you know? And then we go around, and I think it was like my last day of the rotation, and my attending's like, you know what? We'll let you take the lead in here. I walk in there, and she's like completely unresponsive, like won't respond to sternal rubs. And I'm like, listen, she was not like that this morning. So, but I'll say, I think with the inpatient experience, I would have said A tier. But with how much outpatient there was, I'm putting it B tier, above psych, but still B tier.
Okay.
I had a good time on neuro. Like Carter said, I was on our stroke team, which, like as it sounds like, you responded to all the code strokes, TIAs, or suspected some sort of like cerebrovascular accident, and so like that. There was times where that was pretty intense because you really saw people at their worst and saw families at their worst. And the hard thing about the stroke service was, like, stroke is a very long recovery process. You're not going to be fixed overnight, no matter, like, what's done, really. Mm-hmm. And so the stroke team would stabilize them in the neuro ICU, move them to the floor, and then pin placement at a rehab facility. And the rehab facility was really where they made their improvements. And so you never got to see the real fruits of the labor unless you saw them in the stroke clinic 6 months later or whenever they were scheduled. Yeah. And given that this was my inpatient service, I never got to see that side of things. And so that kind of wore on you. But similar to what Carter was saying, I echo the sentiment that residents were really great, attendings were great. I think part of the difference, too, is, as people know, residents start in the summer, whereas we were starting in January.
Yeah.
So we were also being exposed to residents at the end of an academic cycle, whereas a lot of our rotations that we'll talk about later is all at the beginning of the academic cycle, where like people are really fresh and residents are learning how to handle med students. And I think that was one of the benefits of neurology being so early. Yeah. Was that they were used to having us little med students tagging along.
Yeah, not like fresh MS5s as like the new summer interns were. And I think you bring up a good point about like the stereotype in neurology, where it's a really good diagnostic field, but not a great treatment field. Like they're really good at pointing out where things go wrong, but not like doing any sort of intervention. And I mean, even in my experience, like I didn't have any residents my attending was the only neurologist in the entire city, so he was doing inpatient stroke stuff in the morning and then clinic every single afternoon, just 5 days a week. And like clinic for me, I know you were saying like, oh, you get to see the like end of, or like the end product of some of this treatment, but in my experience, all I just saw were chronic migraines, and the treatment plan for it was just like throw everything at it and see if one thing works, which wasn't like that fulfilling for me.
One of the cool things about the clinic that we got to see was there are so many different specific clinics that we went to, and so rather than having a general neurologist who has to do everything that gets thrown at them, we went to a clinic for movement, for memory, for like we have a specific MS clinic that we got to rotate in.
Gotcha.
There was a migraine clinic, a seizure clinic, and so that made the outpatient experience a little more valuable to me as well, where you could see people who were just really dialed in to what they do.
I'm going to zag a little bit. And I think that was like one of the things that made me hate outpatient even more, was because you would do like a day in seizure and you'd be like, all right, I think I'm starting to get the idea for what to do in seizure. And then the next day, or even like that afternoon, you're in like movement clinic. And so I felt like it was really hard for me to like even like get in a good groove of like, I know what's going on.
That's true.
And then also the problem is when you're in like all these like super specialized clinics, like they've already failed like all the first line treatments, and now we're like talking about treatments like that I don't have Anki cards on, that I've never heard of in my life, you know. So pretty much, I would say that I had a not so great time in clinic, but that's also been a recurring theme for me. I know some people who liked it.
So Carter's declared family med. That's a joke. I think Carter's just like had a bead of sweat drop down. But I mean, I don't know. Neuro was interesting. Do you think 3 weeks was enough?
It was enough. It was enough for me.
Not enough like as in like bearable, as in enough to like understand the material.
I thought it was enough. I did fine.
Yeah, I mean, you can definitely make it enough, and I think one of the nice things for us, I guess we should have prefaced this earlier, pretty much all of our rotations are 6 weeks, except psych and neuro are 3 weeks each and put into the same, like, one segment. And we both had neuro after psych, so we were studying neuro while we were on psych, which I think made it a lot more bearable.
Yeah. Like, neuro is just a weird
I
one.
don't know. Psych and neuro was coming for us right after we had finished our last module of brain and behavior. So like all those Anki cards were still pretty fresh for me. And so, I mean, I think that I probably could have taken those shells after our brain and behavior module. Like, I think I was pretty prepared for those shelves.
Hey, tell us more about how you're the Anki master
I mean,
for class.
I think my reputation speaks for itself.
Just drop a comment on his Twitch stream.
Yeah.
He'll give you a ring.
Exactly. I mean, for me, neuro was also like my first ICU experience. And like, I don't know, it was pretty jarring for me. I don't know about you guys, like rounding on people. Well, actually, you definitely know, Carter, because you were saying like you walked in during rounds and was like, oh wow, this person is way altered than when I first saw her this morning. That for me, like I rounded on someone who literally was like diffuse axonal injury, no brainstem reflexes, and that's like that one stings still.
Yeah.
It was, I think, my third real rotation, with the exception of the electives, and that was still pretty rough for me to digest. So, where are we putting this?
I agree with the high B placement. Like, if we had a B+, then I feel like that's reasonable.
Okay, you guys overrule me, because I would have definitely put it C. C tier.
I put it above psych, is mainly
Okay.
how I'm.
All right, we'll go there. Consensus made. I hope this board doesn't fall. All right.
Just be gentle with it.
What next, Carter?
All right, so then after that, we moved on to Ob-Gyn. And that was an up and down experience. So the first 2 weeks was outpatient, which, as I've said before, was not for me. But then after that, I did L&D, which was actually like really, really enjoyable. That was actually one of my favorite parts of probably clerkship was L&D. So like I got to be like really involved in the OR. Like they were like letting me like help close. I got to like play around with the cautery and like buzz stuff. So like I got to do a lot more than like just retract. And then like one of the residents, I said like, hey, I might be interested in surgery at the time. So he was teaching me like all these different types of knots you can do and like why you would do this one versus that one. So I had an amazing time on L&D, especially since it was shift work as well. So like there would be sometimes you were like the morning shift, sometimes you were the evening shift, and the evening was like, I can't remember, it was maybe like 3 to 9 p.m. and then there was like an overnight shift as well. And so that 3 to 9 p.m. shift really fit well with my sleep schedule. So I would say that L&D was probably one of my favorite parts of med school. But also, I went into Ob-Gyn thinking like this is not going to be a good time. But I'll say I think most dudes have said like they enjoyed Ob-Gyn more than they thought they would.
I
So
agree.
yeah, so I had a great time on L&D, and then we do 2 weeks of like a surgical subspecialty of Ob-Gyn, and mine was an okay experience. It was a moment that I realized that I might be interested in anesthesia. So when I was like on hour 5 of retracting, I watched anesthesia coming back from a coffee break, and I thought to myself like that might be the career for me. So at least we discovered that.
Yeah, and I had a little bit different setup to my OB/GYN experience, and I wasn't actually at a teaching hospital per se, which drastically changes the experience that you have. And like the way my rotation was set up, Monday, Tuesday would be in the hospital, whether that was doing deliveries or whether that was like gynecological surgery or C-sections. And then Wednesday, Thursday was in clinic. Occasionally Thursdays would be inpatient or in-office procedure days. So like leaps and other stuff that they can do in the office and don't have to go to the OR for. And then Friday was usually a robotic surgery day. So a lot more OR time than most other people get during OB/GYN. And like I enjoyed the
Did
OR
they have
time.
you do the manipulate?
Yeah.
Did your arm like start shaking? Because mine did.
No, my arm did not start.
Like how long were your surgeries?
I don't know, like hour and a half usually.
Okay, well ours were like 4 to 5 hours.
Yeah, no, I didn't.
So like come like hour 3, you're like switching hands. You've switched hands so many times that both arms are like equally tired. So now you're doing 2 hands. Eventually I figured out that if you like braced both your elbows on your body, you didn't have to use your arm muscles. You could just brace it on your body and just sort of use your core to
Hey,
support.
write that down, guys.
Yeah, that's a pro tip. But yeah, it was a very physically demanding surgery rotation for me.
Yeah. The other tough thing about not being at a teaching institution is patients have the expectation that they're not at a teaching institution. And so
Yeah.
you go to a teaching hospital, everyone's used to having med students around, used to having residents. They're very okay with that. They know that's what they signed up for when they decided to go there. Where you go to a private hospital or like a clinic that's overseen by a private hospital, and it's like, what are you doing here? Like, I don't want you in here. And they're like, obviously always going to respect the patient's desires, but it makes the learning experience different, and you just don't get the same exposure that you would at a teaching hospital.
How many times did you get like kicked out of a room as a
From
guy?
clinic, like daily, multiple times. From OR, that never really happened. It's not as a big a concern, but from the clinic, it was a regular experience.
Kurt, did you get kicked out? Because
I only got kicked out once, and it was the nurse midwife made a really big deal about how upset she was that someone kicked me out. So I'll say that was another. I'd say that was probably like the highlight of the outpatient was I felt very supported. So
Dang.
yeah.
So I did my rotation the same place you did, Carter, and I only got kicked out on L&D when it was either like a staff member who works at the hospital, which I understand.
There was
like,
one resident who was delivering when I was on L&D, so I didn't. They were like no students for that.
Yeah, and that one I completely get, because like, man, if I bump into you like on my 4th year rotations, this is gonna be real awkward. But then there was also one. The only other one that I got kicked out of was the mom was 18, and I was just like, you know what, fair enough. But honestly, I really enjoyed my OB rotation, given this was my first rotation. So I still remember the first day being on my surgical subspecialty part. And this was my first time figuring out what rounding was, first time figuring out what pre-rounding was, figuring out how to like present, then going to clinic, and then going to the OR, all in the same like 14-hour day. That was my first day of clinical rotations period. Yeah. And I remember burning hey, this is my first rotation, I'm just the new med student card very often.
Yeah. Yeah, and it's like what we were talking about, psych. Your experience is going to be dramatically different than our experience, given that that was our 3rd rotation.
Yeah. But I think overall, I liked it. Like, I want to mirror the symptom. Huh?
C tier. The L&D was great, but
really,
everything else, not for me. So everything else drags it down.
David, I'm curious too, because like obviously you have somewhat of an interest in pediatrics. I found it almost like a pre-ped, so I kind of enjoyed it.
Yeah, I think I would have had a very different experience if I was at a teaching hospital. I loved my attendings. I liked the handful of residents that I got to work with. I loved our days in the OR. I felt like they included me. And even when I was in clinic, I felt like the attendings really worked to try and include me if the patient was comfortable with it. But it also just sucked having to like sit in the hallway for a lot of the clinic time. And so I'd be okay giving it CT, or like,
dang.
I don't want this to like make anyone be like, oh, OB's gonna suck, because it was a good rotation.
I'll say I enjoyed OB more than I thought I would.
I was gonna put it A tier, really, but we'll balance it out. You wanna do a B tier?
We want to do like low, like on the line between B and C.
You can put it at the top of C. That's where you can put it.
All right.
But like,
I'll do it here.
It may also be interesting, like saying what did we think we would have rated it going into it? Because I would have given it an F.
Yeah,
going
I would have
into
given it
it.
an F going in. I would have given it an F going in. So I will say I enjoyed it much more than I thought I would, but still,
we're also
only
3 guys who aren't interested in OB. Like
this is
that's
also
going to influence how we rate this. And we've got plenty of great like men and women from our class going into OB.
OB's popular in our class.
It's probably the 3rd most popular, especially, I think.
It's either 3rd or 2nd.
Yeah.
Wait, what are the first 2?
Surgery.
And from what I've seen, IM and peds have a ton, like each 30 plus. IM like 40 plus.
Then I would say surgery would be 3rd, and then probably OB 4th.
Yeah.
Although some would debate that OB is also surgery. I'm not going to contribute to that conversation. You guys can have fun with that. All right, Carter, let's keep us moving.
Okay, after that was peds, which was also another one. We'll start by saying that I thought I was going to put an F tier. Well, I'm just not a big fan of kids. I think one thing that also really grinds my gears is for some reason, a lot of people in the pediatric field refer to kids as kiddos, which I don't know why, but it just bothers something deep inside me. So between those 2 things going in, I thought it was going to be F tier, but I will say that I enjoyed it. Once again, it was another one I enjoyed a lot more than I thought I would, but still wasn't like one of my favorites, because like the first 2 weeks for me was like your pediatric primary care outpatient, which was like the 5th circle of hell for me, like easily one of my like worst outpatient experiences, not because of like the faculty or the way the rotation was set up, but just it was, everything I hate about outpatient care, where it's managing lots of chronic problems, which is not something I like. It was a lot of just reassurance, a lot of just like offering parents guidance.
They're kids.
Yeah. Okay. Well, so like I prefer more of like someone's bleeding out. Let's do something right now to save their life. And there is absolutely nothing there was nothing urgent. There was like a couple like upper respiratory infections I saw, but there was nothing urgent going on. I think there was like one like febrile infant that we had, so that was like at least something to like think about. Like, okay, well, what could be causing the fever? Is it a UTI? Is it this? Is it that? Like that sort of thing. So, a lot of otitis media. So I got real good at trying to look in someone's ear,
pretending that you saw them.
I got real good at saying like very like non-committal stuff as like, oh, it might have looked a little erythematous. I think I saw some bulge, but I'm not quite sure. Like that kind of maybe a small effusion. Like lots of hedging. So I'd say outpatient was that's where we started. Then I did a week of outpatient subspecialty, which mine was peds onc, which I thought would be like the most depressing, sad thing in the entire world, and that was actually one of my favorite experiences in med school was doing that. So there was I won't get into the details, but there was like one kid who was like very impactful that I saw that like actually made me cry that day. So it was like happy tears, not like sad tears. So it was definitely one of the highlights of my med school experience. Then after that was the newborn nursery, and that was like the easiest hours I have had in med school so far. It was really chill. The attending was great. I'm just not a big fan of babies. Like, some people like want to pick up and play with babies. Not me. I'm more of like a so I think your mileage will vary with newborn nursery, but I loved the hours, did not enjoy the work a whole lot. And then inpatient peds was basically just like IM for kids. So that was something I actually kind of enjoyed. It was my first introduction to like long rounds and that kind of stuff, and like writing long progress notes. So that part I didn't necessarily like, but at least the thinking through, all right, this person has an acute problem, like they have mastoiditis, and like what do we need to do to fix them, like that sort of stuff. Or there was a lot more like life or death interventions going on, which was something I enjoyed a lot more. But the rounding for hours, and then like your feet killing you, and trying to figure out like how to do like the resting against the wall without making it look like you're like that's what you're doing. The dissociating on rounds when they're you've only got like 3 or 4 patients that you're following, and then there's maybe
you get done presenting your patients, and then it's just like
you're like you want to stay engaged because it looks bad if you're just spaced out and they ask you a question and you're like what. So, you definitely want to stay engaged, but like it gets really hard when it's like not your patients and like you have basically no idea what's really going on with them. I think it's a lot easier like if you are in the field or like you're interested in the field and like you're thinking more about like, oh, what would I do in this situation? But it's really hard to stay engaged when it's just not your cup of tea. So
you could say that for any of these rotations though.
Yeah, and I had, again, a little bit different experience. I was at a regional hospital for 4 weeks, and this hospital oversaw an associated clinic. So I did 3 weeks in the outpatient clinic there, and 1 week in their newborn nursery before doing 2 weeks of inpatient. And the inpatient was at like our main teaching institution, so that was more in line with everyone else's experience, but my outpatient experience was great. Had great physicians that I was learning from there, great residents.
Didn't you get fed there?
Yeah, I did get fed breakfast and lunch.
That
plays a factor.
Yeah,
but
putting it out there, that's a big part of how much you enjoy a rotation.
But the attendings were also very intentional about like doing teaching time with us each morning before clinic, and not like a teaching time that felt like a chore, but like one physician in particular, he tried to teach things that weren't like stuff that we were already studying or learning about necessarily. Like high yield shelf topics, but he taught more like, oh, this is like stuff you should think about when signing a contract as a resident or an attending. This is how you should approach like trying to save money while you're a resident or an attending, or like, so we went into like 401ks versus like Roth IRAs.
Yeah.
So like
life stuff.
yeah, and he was like,
Backdoor Roth IRAs. Did y'all talk about those at all?
yeah, I think so.
Yeah.
Yeah.
So I really appreciated that about the rotation as well. He was like, I know you're gonna study like the skin rashes.
Wait. Did he teach you that $1 today is worth more than $1 tomorrow?
No.
That's like the golden rule of finance. So you're welcome.
Okay.
Yeah.
Coming back now.
Yeah.
So I loved that about the rotation, and I felt like he was very invested in like students and residents and really wanted the best for them outside of like being good practitioners of medicine. So I thought that was super cool. My newborn nursery was also a little bit different experience because at the regional hospital we didn't have a NICU, and like a well child nursery we just had the nursery. So unless it was like baby crashing needs to go to a high level NICU, then we got everything else that came in. So like we were doing spinal taps on newborns.
You were?
I was not.
Okay.
My attending did one, which like I don't think I ever would have seen at like a standard newborn nursery. We had to like intubate a baby prior to being transferred to the NICU. I got to practice some simulation experience on like newborn dummies. And then we also, as a part of the newborn nursery there, went to any delivery that wasn't just your standard run-of-the-mill vaginal delivery that like you didn't expect any complications from. So any twins, any C-section, any mom with risk factors for her delivery, we were in the room and like did the skin-to-skin contact, and then we're doing APGARs in the room, which was another cool part about that rotation. And then finished it out with 2 weeks of inpatient on the Peds Hem-Onc service, which when I tell people that, kind of like what Carter was saying, like, oh, that must have just been the most depressing thing that you ever saw. And it's actually not. I really enjoyed it because we were treating cancer, but it was also treating a lot of complications of cancer, whether it was an infection or someone's got febrile neutropenia or whatever it may be. We also got a lot of sickle cell because like that falls under our heme umbrella. So overall, good experience there as well.
I don't know. Like I say, I came into med school wanting to do some subspecialty within pediatrics. I enjoy working with kids and parents. Surprisingly, I kind of mirrored Carter's sentiment about the outpatient experience, though. I knew that like outpatient peds would bore me to death all day long, which it did. Like my pet peeve of that entire time was doing well visits. Those sucked because I was just like, I don't know what to talk to you about.
I gave the absolute worst presentation I have ever given when I was on outpatient peds. Like my brain just shut off. I was like, I don't know what to ask them. There's nothing going on. Like I don't know what to tell you. Like the kid's fine. Like,
assessment and plan. Keep living.
Yeah.
Like
breathe.
Yeah. So that was one where I'm like, yeah, outpatient was rough. Inpatient, those were definitely some of the worst hours that I've worked, and I was very, very tired because I worked 12 days straight. And like getting there at like 6:30 every morning for handover was definitely an experience. Just so happens I was on like the general floor team, but we also specialize in nephro. But I swear our entire patient list was like RSV bronchiolitis, asthma exacerbations, my entire 12 days that were there, with the occasional like random nephro issue. Yeah. But like, yeah, you learn to sit when you can, dissociate when you can, and then just like lock in for those couple patients and kind of move on. And then newborn, I mean, like again, I just enjoyed working with parents and kids. Like, it's always exciting to share in that moment of like welcoming a new person into someone's family, and it's an exciting time for the moms and dads. I remember I was able to like work with one of the anesthesia faculty members when he had his like first kid, and I was just like, oh wow, this is cool. Fancy seeing you here. But overall, I enjoyed it simply because it was like the patient population I wanted to work with. So
That just reminded me, when I was on my neuro rotation, I had to, we were consulted on someone with a headache, and the person ended up being the wife of a faculty member. So I had to have a faculty member observe me while I'm doing a neuro exam, and that was definitely one of the most nerve-wracking things I have done.
like shaking
Yeah,
as you're trying to get reflexes.
Fortunately, as I brought out my reflex hammer, he like said something to the effect of like, "Oh, I haven't used one of those since med school," and I was like, "Thank you, God."
It's like that Glockenflecken video where the med student has to do his like neurophysical exam on the neurologist. He just absolutely rails him the whole time.
Yeah.
That's a good one.
Alrighty, pediatrics. Where are we putting this?
I mean, I'd put it S tier. I know Carter's
Really?
not going to agree. Yeah, I mean, I also, to preface again, I went into rotations dead set on ophthalmology. That's what I wanted to do. If I did ophthalmology, I was going to do pediatric ophthalmology. Like for various reasons, ophthalmology has like shifted from like dead set number one, and like pediatrics has floated into that top slot. So obviously personally biased, but yeah.
I would say A tier for me.
You know, I'm not gonna rain on y'all's parade.
No.
No. Come on.
We need an average.
I mean, I would have said maybe under Ob-Gyn, despite having like two bright moments. You know, I would have put it.
You can stick like A minus, A to B.
Sure.
A to B tier? All right, Carter, get us going on the next one.
So the next one was IM. I had IM next.
Hey.
So my first 3 weeks were so we did like 3 weeks of subspecialty, 3 weeks of just general IM inpatient. My first 3 weeks were with infectious disease, which was the moment that I really like solidified and like I want to be an anesthesiologist, because there's like a lot of like stereotypes about like infectious disease and like them being very long-winded, being very like cerebral. It's a very cerebral field. There's very detailed notes. There's very, very long rounds, easily the longest rounds I've ever been on.
You also rounded like twice every day, right?
Yeah, we would do table rounds, and then we would do...
Bro, I remember those
Yeah.
sex streams
Yeah, we
of
do,
like, I'm still here.
Yeah, it would be like 6 p.m. and we'd be finishing up rounding. So, that was rough, but, I did get to have like a lot of patients that were in the ICU, so that was really cool. That was, I enjoyed that part, but the really, really long rounds and the very long and detailed notes were just not my cup of tea. So I did not enjoy that. Then when I was on general IM, that was so the first like 2 weeks of that, I thought like, you know what, maybe I want to do IM. And then like the teams changed. I realized like I just absolutely like loved that group of residents. Then that like it's not that the next group of residents was bad. It was just that like that first group of residents I with were like, they were all like really funny. They all had like my same sense of humor. Like it would, like when we were on call, it literally just felt like I'm just like hanging out with the boys and girls. There was a couple ladies, there was a couple of girls on the team, but like it literally just felt like hanging out with my friends. And then every once in a while we'd go do like the little medicine things and round. But there was a couple times I felt like very doctor-y. Like there was a girl I got to see with pyelonephritis who, like the ED calls up and they're like, we've got someone to admit, that sort of thing. And then I got to be the one to go down there. I interviewed her by myself. I came up. I gave a plan that was completely wrong. And then, but then, I followed her for the next few days, saw her get better, and then, get out of the hospital. But, I definitely missed sepsis, I think, on every septic patient I had.
That's not good.
But I mean, there was, but I mean, in each time there was like there was like one time that like I had read like an article that said like colon cancer can cause a high heart rate, and so
in the med student.
yeah. So like, anyways, I'd read this article and I was seeing this guy, and it sounded like colon cancer, but also could have been like real bad diverticulitis, and it ended up being like real bad diverticulitis with like abscesses, like giant abscesses in the liver. And so like I was talking to the attending, and I'm like, yeah, I think it's like colon cancer, and I think his heart rate is elevated because of that. And he's just like, he's septic. He is horribly septic. He is septic. That is what's going on.
That is
here.
pure recency bias right there.
And I was like, oh. And then like the same thing with like the girl with pyelonephritis, because like she'd had a history of like some like inappropriate like tachycardia syndrome or something like that. And I was like, yeah, I think her tachycardia is just because of that, and like yada yada yada. And like, so I don't think she's like septic. I think it's just pyelonephritis. And he's just like, she is septic. She needs cultures, antibiotics, the whole, like, she needs the sepsis bundle, you know? So that was definitely a learning experience for me. But once the teams changed, I realized that I didn't really enjoy the work of IM as much as I enjoyed that group of residents and hanging out.
I know exactly where I'm putting IM. That's all I'm going to say.
Yeah, I had a good time on medicine. I did 3 weeks of general internal medicine, and then I did my last 3 weeks at a local Army base at the hospital on base, which was a very unique experience. But my general medicine team had a great time. I felt like our clerkship coordinator, his big phrase for this rotation is like, take ownership of your patients. That's like his shtick that he likes to like really make
loves that phrase.
Yeah. And I felt like I did get a chance to like actually take ownership of patients and really invest in their care, which was a little bit different than some of my prior rotations. And like, if nephrology had a question about one of our patients, they would message me, and like then I could relay it by the attending or whatever. And so I felt like I was always very involved, because it's easy for a med student to be like left out of the loop when decisions are being made. And it's like, oh, like, cool, good to know that's the plan. But I felt like that happened less on medicine for me. I also felt like I really built some cool relationships with patients, where like one lady in particular had to get percutaneous nephrostomy tubes and was just very anxious, very worried about the procedure. And she was like, are you going to be down there with me when I get this done? I'm like, no, I'm sorry. Like, this is going to be interventional radiology. We as the medicine team don't have much of a role in this. And I was like, but how about this? Like, I'll come by, hang out with you in the room before they wheel you down. So I was able to spend like 15, 20 minutes with her, just like really trying to calm her nerves and prepare her as she went down, which was like a really special moment from that rotation. And then my time at the Army base, it was good. It was just a lot harder because, like, as a non-military person in the whole military system, I just felt very out of place the whole time. Like, I didn't quite understand all the nuances of their system. And so it was much more difficult to take ownership and be integrally involved. I just felt like I had kind of a hand tied behind my back the whole time. So loved the people, loved the patients, loved the attendings, loved everything about it. It was just hard being from the outside, flung in there for 3 weeks and then snatched back out.
Definitely. What you were saying about like building close relationships with the patients and everything, that is equally why I loved and hated medicine, just because medicine was the moment that I realized I can't do longitudinal care. Because just as much as you have your patient ownership and you come in every day and possibly see them get better, on my 3 weeks on the cardiology floor, those were 3 of probably my worst weeks of med school, because I would just come in and see people suffer. And we couldn't do a single thing about it. And, you know, as much as you have that patient ownership, I was like, just like personally, I was taking some of that home with me every single day. And I was just like, I can't do it. And I would come in way early for rounds to, like you said, just sit and talk with some of the patients that needed me. And I talked a lot about my experiences in like one of my other videos I made, as well as a TED talk I gave, where it was very much like the most transforming rotation, but also like the most sucker punching one.
You also had it second, right? You had it right after OB, which I think doing medicine early is hard.
Yeah,
Like,
so I should say I had mine in June. So like all of my interns were basically second year residents. So that I think that played a big part. Yeah. And
all of your second year residents were basically interns, or all of your
no, all of my interns were basically second year residents because it was June, right? Because they start in July.
Okay.
They're all basically second year residents, and then everyone else is basically another level.
And I just came off of medicine. It was my last rotation, so I had the benefit of having every other rotation, like building maximum fund of knowledge before going onto the medicine service.
Yeah, having it second, like I think it's good, but it's also it sets you up well for the rest. But just be prepared for it to be a very, very rough time, because you have long hours on top of like you don't even know half the stuff to write in your notes and plan wise. But yeah, my residents were incredible. I mean, some of them literally had to debrief with me. So I thank them so much for that. But like the cardiology floor, definitely the most growing experience of med school. And then I did 3 weeks of general at the VA, which VA is a chill place to do an IM rotation. It's the VA. I'm not going to elaborate anymore on that.
Yeah. And the other thing is like what we were talking about, having medicine at the end being an advantage. There is pros to doing it second, like you did. Like med school as a whole, the analogy is like drinking from a fire hose. Like medicine especially, you're learning so much in such short amount of time that it really does prepare you for rotations later down the road when like
there was questions on my Ob-Gyn shelf that were literally IM questions. It just happened to be a female patient. Where it would be like, this is a female HIV patient with pneumonia. Was the most likely cause of her pneumonia? And like that is a straight up
medicine question.
Exactly. That happens to be a female patient.
Yeah.
So,
now where are we putting this? Because
F tier.
Okay.
I would gladly.
I'm putting it F tier. I'm putting it F tier. Yeah. No, like that's okay. Good that we all agree.
I mean, we don't all agree, but
yeah. No, we agree.
I would gladly put it in A, but
no,
I understand why we're not.
No, I'm putting it F tier. All right.
Yeah. I would say that I realized. I think someone told me that if you like internal medicine but hate talking to patients, then do anesthesia. And I would say that definitely applied to me. That
hey, any programs listening here?
No. So here's the thing: is I love the pathophysiology. I love the physiology. I love thinking about problems and thinking about like what could this be versus other things. Like I loved all that sort of stuff. But the real thing is like I just hated the rounds and hated writing notes. That was like the number one thing. And then it's not that I hate talking to patients. I think there's a very common misconception.
Just have to clarify that.
I don't hate talking to patients. It's just not something that gives me like satisfaction and joy and like that kind of stuff. It's not something I love.
Have you considered pathology?
And what I do enjoy is talking to people in like moments of crisis, like that kind of stuff. I prefer like really impactful, short interactions rather than just sitting in someone's room and talking with them for like an hour.
So does that mean surgery's next to discuss?
No, next to discuss is the rest is our electives. So
we'll save electives for the bonus ones. Let's go to the core ones to finish up.
Then the next one is surgery, which I did 3 weeks of surg-onc and then 3 weeks of ENT. What are you?
Are we missing one?
We haven't done family yet.
Oh, family.
Yeah.
Okay.
Yeah. But anyways, so I had gone into this rotation thinking maybe I'm going to do surgery. I had also gone into it thinking like if I was going to do some sort of surgery, maybe ENT. So I was going into this rotation with very high hopes. And, at the end of the rotation, that was when I really decided that I do not want to be a surgeon. So I heard someone say that if your favorite room in the hospital is the OR, then be an anesthesiologist. If your favorite room in the entire world is the OR, then be a surgeon. I would say that definitely applies to me, that if I'm going to be in the hospital, I want to be in the OR, but, you know, like I definitely do not live and breathe surgery.
Apex and your Roth IRA is calling.
Yeah, exactly. You know, like there's some people who just like absolutely like cannot imagine life without surgery. And like I had like a lot of fun like practicing sutures and like learning, like I really enjoyed like the technical aspect of it, of like, so like I feel like one of the reasons why I'm a borderline pro at video games is that I'm willing to just like sit there and do the stuff that a lot of people think is boring and repetitive, and like I'm willing to like do that kind of stuff. So like sitting there and practicing suturing and like mastering that skill was something that appealed to me, but there was other things about the rotation as a whole that did not. So
You did love the trauma call, though.
yeah, so I will say the trauma call was like the single greatest experience I have had in med school, and is enough. Even though I did not enjoy almost everything about the rotation, I love trauma call so much that I was like really still considering doing surgery just to do trauma surgery. But the problem is that I would be 37 by the time I'm done, and that you know, there's like 5 years of general surgery that you have to do, and you have to enjoy. It's going to be a long 5 years if the only thing you want to do is trauma.
Yeah.
So for that reason, I decided it was not the field for me.
For those reasons,
Yeah,
I'm out.
But trauma was easily like my number one experience of med school.
Yep. I had two of arguably the best surgery rotations at our institution in terms of like what's good for students. I had urology and ped surgery, and especially being interested in peds, like ped surgery was especially valuable. Urology was super cool, and a lot of urology isn't like, I don't know the best way to put, like not fully surgical. Like there's a lot of procedures that are done in the OR that like are cystoscopies with a biopsy or
TURPs.
Yeah, a lot of scopes, a lot of like procedures that are like potentially devastating if done wrong. Like it takes great skill, and like there is an art to it, but like they're not long procedures. You can see a lot in a day. So I enjoyed that much about urology. It was a great group of people to work with. I said this repetitively, like the urology residents at our hospital, I felt like we're enjoying like their life and their work more than a lot of other residents in the hospital. They're able to lead a decent work-life balance, still learn a lot. And it's not a big program either. There's only 3 in a class at our institution, so they became incredibly close. And it's like they were going to play like rec kickball together or different stuff like that. And like that was really cool to see. It's like, oh, like residency can be really enjoyable if you like know what to look for and do it well, which was super encouraging about that rotation in general. And then ped surgery was great. And yeah, again, probably a little bit biased here, but the attendings at our institution are all
really good.
Yeah, they're all really good. And I mean, ped surgery is like universally known as one of the hardest subspecialties to go into.
I think it is the hardest one.
Yeah, I think this could be wrong. Nobody quote me on this, but my understanding is there's somewhere between like 100 and 200 fellowship positions each year. And I think on the lower end of that. And some programs like will offer a spot one year and then not have a spot the next year. And so really some of the best and brightest surgeons. And it was cool to see, okay, if I do go become a pediatrician, like what kind of expectations can I set for my patients if they're going to need surgery? How can I best prepare them for that? And they also like let me do a decent amount, which I enjoyed about as well. Same with urology. I felt like I got to be more involved in the OR than some surgical rotations allow for.
Yeah. Just like speaking of involvement too, it's like, well, for one, Ob-Gyn was my first real personal exposure to the OR. And that was kind of when I said, oh, wait, this is kind of cool. I enjoy being on the surgery side. Like scrubbing in and gowning up felt like, Tony Stark putting on an Iron Man suit. And, I just came off my surgery rotation, so it's still kind of fresh. And I knew I wanted to be in the OR since then. It was just trying to figure out which side. And I think I had a lot of misconceptions about surgery as far as like the hardcoreness of it all. But I did both of mine not at like community sites. So I did orthopedics at a community site as well as my general. And because of that, I didn't really have any residents to like fight for first assist chances or, being, I think, closer to what was going on. And because of that, I really, really enjoyed it. Almost like I didn't want to enjoy it, but I still did. It was an odd feeling. But I think it satisfied me personally where like neurology and IM didn't, where like IM just felt like we're treating lab values and we're not really making tangible change. And I know that's not true. You definitely are. It's just like, for me, I loved seeing, okay, bone broken, reduce, bone put back in place. And like there was no like guessing of, oh, did this work? It's like, it absolutely did. And I don't know, I genuinely enjoyed it. It was definitely like long hours, but it was one of those weird things where I didn't really mind being there for a while. It was a place where I got to see cool stuff. The attendings and the one resident I work with was very good at involving me, which I think is a huge like variance.
There is nothing more miserable for a medical student than being in the OR, being forced to scrub in, and then being like the fifth person in line where like you're scrubbed in, hands on the table, but you literally can't see anything because they're operating like deep in the abdominal cavity. So you have no view. You have no view of what's going on. You're not even retracting. Like you're literally just standing there doing nothing. That was absolutely, because even if I'm going to be in that situation, I'd rather not be scrubbed in because at least I can move around and get a better view, or I can go over and like talk with the anesthesiologist on the other side of the drapes and at least learn something. But that was easily my most miserable experiences in all of medical school.
So where are you putting surgery?
So I'm going to put it C tier. I absolutely loved trauma call. If trauma call alone would be S tier. Like, I mean, I came, so like, I think our call shifts were only from like 6 to midnight. And I came home after like my trauma shifts and I would like stay up till 3 a.m. because I was still so wired from like the adrenaline and like how cool everything was. But there's a surprising amount of clinic in surgery. I'll say that surgery clinic is much more enjoyable than most other clinics. But like ENT clinic in particular was like, I think ENT was the only clinic experience where I've been like, I actually love this. Like I liked general ENT outpatient clinic.
Why are you putting it a C if you're like, I like this about it, I like this about it?
I'm saying there were some highs, but the experience of being number 4,
in the pecking order,
on the depth chart.
In general, like any of these rotations, there's a direct correlation between like enjoyment of the rotation and involvement of the student.
I think that's a good conclusion.
I like intellectually, I know that my experience as a medical student on the rotation is not what like being a surgeon is, but like it is just like so hard to like separate that from like my actual experience, like my like what I actually lived through, versus like what I know a surgeon does.
So your C, where would you put it?
And this is because I went in community sites. I'd say A.
I would have put low A.
Y'all can throw it in A.
A, because here's what I'll do for you.
Put it in A. A is looking lonely.
All right,
put it with an asterisk.
No, we're gonna do surgery and then trauma. Right in parentheses. Okay.
All right.
We're almost done.
Yep. So then the last one was family medicine.
I got real high hopes on this one for you.
So how did outpatient clinic for 6 weeks feel?
Yeah, so actually, it was actually quite enjoyable. It was better than I thought it would be. It was another one of those going in, I was like, this is going to suck. It was better than I thought it would be. It was the most doctory I have felt the entire time. And I think that a lot of that was because it was my very last rotation, so I had the biggest breadth of knowledge. But also the nice thing about family medicine clinic is like in contrast to like the neuro clinic or ENT had this problem to some extent as well, where general ENT clinic was really enjoyable, but like there was also subspecialty ENT clinics where it's like this is the voice clinic. And like I don't know how much we learned about voice in medical school, but like basically nothing. There was like an ear clinic and like a sinus clinic, and like people are going there because they have failed all the first or even second line stuff. So family medicine is where like a lot of the first line stuff that I've actually learned shows up, and like it's a lot of stuff I've like actually heard of. And then, like I said, it was also the last one for me, so I had a good fund of knowledge. So like I felt like I could, see. So they'd be like, all right, I'll go see this one. This is the next patient coming in. You go see them. And that gave me plenty of time to pull up to date, type in approach to, insert chief complaint, and it would tell you, and like if you gave me like a chief complaint of back pain, I can walk in there and sort of just wing it and like do an okay job. But like just have the time to like read, like, all right, this is like, these are the common things to think of, but also make sure to ask like these questions. I'd be like, oh, I didn't think about ruling out like aortic dissection, like that kind of stuff. So, I felt like very prepared for every patient encounter I had. Sometimes they would like bring up something and be like, oh yeah, by the way, I've been having this like shaking in my hands. And so then you would be like, okay, well, let's figure out like what's going on here. And then you'd be like, I think this is an essential tremor. And you'd tell the attending, like, I think she has an essential tremor. Let's try propranolol. Like she also has like a history of hypertension. I think the propranolol would be good for her. And they'd be like, you know what? Sounds like a good plan. Let's do that. And that was like the only time I've had like that experience where they're just like, you know what? Like, hey, it sounds good. Let's do your plan. So that part was really cool, but 6 weeks is a long time. And I think towards the end of it, like I sort of like entered like the twilight zone where it felt like every day was just a repeat of the day before with, I would say like one patient out of the day would be like some interesting chief complaint with like chest pain or something like that. But then everything else would be like just follow up for diabetes, follow up for cholesterol. And I could see how that could appeal to some people, but it felt to me like I entered like a twilight zone where I was like, I don't even know what week it is anymore. So
yeah, I would rank family medicine moderately high. I had a good experience. I was at our home institution, and I also did it like right in June as the third year residents were coming to a close. I guess May or June. And so they had like a very solid fund of knowledge. They were great teachers, and I got to work a lot with them. And one resident in particular be like, hey, I don't want you to write any notes today, but I want you to see every single patient that comes through this door. I'm like, okay, that's a fair trade. So I got to just see everything, got to talk about so many different things with patients, and I felt like that was much more valuable to my learning experience than like, okay, you're going to see 3 patients today and write the notes on all of them.
That was the thing that I finally learned on family medicine clinic. The thing I had hated the most about every clinic before that was like, say I'm in like the head and neck cancer clinic and they're seeing like 8 patients that morning, or maybe like 9 patients that morning. If you're the only one seeing them, then that's a pretty full morning. But the thing is, as a medical student, there would be the attending, a fellow, like a senior resident, maybe like a more junior resident. So like basically I'm seeing like 1 out of like every 5 patients. So it'd be like not uncommon for me to see like 2 patients in an entire morning.
That's
and
how
so
Pete's
that
clinic was for me.
Yeah, so like that part definitely sucks because you're just sitting there for so long. So like there's like stuff you can do to like get some studying done, like read up read up on the next patient, like that kind of stuff. But that was the thing I enjoyed more about the family medicine clinic was it was a little bit faster paced. I was seeing a lot more patients.
Yeah. And
So,
everybody in family medicine, for me, kind of like what you were saying, was very intentional about asking, hey, what's your plan? And I had it earlier on, like I was saying, so it didn't have the same fund of knowledge, but it did. This was the first time I really started thinking, like, okay, like these are the problems. What do I actually want to do about this? Which does make you feel a little doctory and feels like you have some agency in this situation, which, like I was saying earlier, like the amount of med students involved is directly correlated to how much you enjoy that experience.
Yeah. And I mean, honestly, I would like to mirror it all because, like, this was the first time where my attending was like, I love your plan. Let's do it. And I was like, oh, I know a thing or two. And to be fair, like, a lot of the visits were definitely social visits kind of deals where you just, like, show up and you talk to them and you catch up, which, again, I understand some people can find fulfilling. But honestly, this was the first rotation I saw everyone from, like, the ground up having wellness as a priority. Like, we were all eating good. My attending would leave every lunch and go on the bike or go on a swim for a little bit and then come back. The MA that I was working with lost like 65 pounds over the past year, and they all just like really took care of the students, and it reflected in the way that they care for their patients. And I just like, but with the exception of it being monotonous, I would say it was like the first time I felt like, wow, I might be able to do this whole doctor thing and, enjoy my life at the same time. I have everything good to say about family med except the shelf. That was a horrendous shelf.
Sorry, Andy.
yeah.
That was terrible. I feel like I was taking another family med like test. Just me?
I don't
Okay,
agree.
cool.
Yeah.
Yeah.
Sorry.
All right,
Yeah.
dang. I thought it was terrible, but where would you put it? Because I know where I would put this, honestly.
I also got fed on family med a decent amount, which like
Yeah.
bumps it up a little bit. I'd put like pretty high B.
You would put it S tier?
I would honestly put it S tier.
I was thinking maybe like a low A, like 89.5, like it just rounds up to A. I would say like the first 2 weeks were great. After that, sort of got repetitive. But
We'll
we
put
can go
it
mid A.
hard stuck A. Let's do that. All right. And so I know this is probably like the longest Beyond the Scope episode I've recorded up to this point. So let's do rapid fire for our electives here.
respiratory care, S tier, undisputed S tier. Pretty much outside of trauma was the only time I have thought, wow, I enjoy medicine in like the last year.
Yeah, I had a research block, which I had a great time with the PhD student that I was working under. Phenomenal. I got A tier. I like that I could kind of make my own hours, had more like control over my day, and I got to see like a poster come out of it, which is cool, and a pub.
Nice. Oh, you just did a study one for the second one, right?
Yeah.
Okay. Simulation education, S tier, because literally it's the easiest rotation ever. The simulation department here is incredible. I just did like media productions for them and help write cases for the next year, which like I love and enjoy. Anesthesia. So remember your whole chart about like the enjoyment is correlated to your involvement as a student? I think it is very, very difficult for students to be directly involved in anesthetic care just because, like, there's a lot of liability involved in it, but two, after you do, like, induction, you want there to be no more involvement. If there is more involvement, that means something went horribly wrong. So, like, I mean, there were definitely days where I showed up and I was like, I don't really know why I'm here.
Yeah.
Because
There's some things that are just hard to do as a student. Like my friends who did neurosurgery for their surgery rotation, it's like you just don't get to do that much because of the nature of the medicine. And like if there's residence fellows, CRNAs in the case of anesthesia, CRNA students, like there's a lot of people that have a step up on the old med student.
Yeah, I think there's definitely room for improvement as far as like how to get students involved. But like I would say if I did it at like a community site, things would have probably gone a lot better. But, you know, like you said, there's CRNA students, there's paramedic students too. And then like our ENT program, or not ENT, OMFS program makes them do like 6 months of anesthesia. Yeah. So it's just like, dude, I'm not gonna take an airway from like an OMFS resident.
Yeah.
So
there's people who need to get these procedures.
Yeah. And so it was very, very hard for me to like get a good idea of what the field was, even in 4 weeks.
Yeah.
So for that, I'm really like, unfortunately, as much as this hurts my heart, I have to put it F tier. Oof. I'm not even. Yeah, like it was just a tough 4 weeks to be a medical student. I think if you involve the students a lot more, it has the potential to really be all the way up here. But that mileage can vary so much. But yeah. So this is the completed tier list for our third year of med school. Any closing thoughts? Because I know we're all like tired and we all have like boards to take now, but what would you suggest people do?
Yeah, I think like if I've gathered anything from this conversation, it's no matter what school you're at, what program you're kind of in, when choosing your rotations or electives or whatever, really look for student involvement. Like your ENT rotation was brutal because you had to just sit there in the corner. It's not because what they were doing is necessarily uninteresting or like the outcomes that they were able to achieve. It's just like there's nothing for me to do. And like at this point in our learning, we're learning by doing a lot of the time. We're at least learning by really being able to watch closely and ask questions as someone else is doing. And when neither of those things are an option, it makes the experience significantly less enjoyable and you get less out of it. Yeah. And so not that like IM was a bad learning experience because we all learned a ton on IM, but like it was tough.
Yeah. Carter?
Yeah, I mean, I think that figuring out OR versus not OR is like the first step. I think that it's really important to like be very proactive about like asking to do stuff. That was a lesson I learned the hard way. Was like when I was on OB, I felt like the residents there were very good about just like handing me the cautery and being like, "Go nuts, kid." But I felt like on surgery, at least in my experience, I had to be a lot more proactive about asking to do stuff. Otherwise, I was not going to be involved at all. So that was my lesson learned.
Yeah, and that involvement is like a two-way street. You know, it's both, hey, assert yourself and ask and be present, but also like it does take some work on the resident and faculty side to be willing to involve the students. Yeah. So yeah, I think there's a balance between knowing what you wanted to do before third year and then selecting like community versus academic site with them. I would say without a doubt surgery. If you have any sort of inclination that you want to do surgery, do it at community sites. Carter, I know we've talked about this. I feel like you would have definitely enjoyed ENT and surgery more if you did not an academic side, just because you would have been involved more.
Yeah, I also
maybe, but we'll never know. So
I've also started saying if you're interested in surgery, specifically general surgery, try and do an ACS rotation. Like that is the bread and butter of general surgery. And gives a really good insight into what life as a surgical resident will be like for 5 years and can be helpful in making that decision.
Definitely. And then other than that, just like really try to enjoy time. Also like learn to find that balance between when to study or how to study. Like you can't sit through lectures and do just pure passive reading over third year. This is just impossible. Yeah. So practice questions to your friends. Mr. Anki over here can testify to Anki's effectiveness. I mean, I used it throughout the year.
Yeah, same
helped
here.
me. But other than that, man, we got some boards to take, and then season 2 of Beyond the Scope will resume after that, probably sometime mid 2023. So, any closing thoughts for the med students and pre-meds possibly watching or listening? I don't know why you've listened for this entire time.
It went by quick, which was a lot faster than I ever thought it would be. Like, it's hard to believe that psych was a year ago now. Doesn't feel like that.
Yep. I mean, I think I've said everything so far. So,
Yeah.
nothing to add.
It'll go by fast. So, good luck to all the students starting their clerkship year at the beginning of January. And we'll see you again in 2023. Thank you so much for watching or listening to the Beyond the Scope podcast. I hope you enjoyed today's guests, and to make sure that you don't miss a single episode, make sure that you follow Beyond the Scope on all streaming platforms, as well as if you want to see the full video cut, subscribe to my YouTube channel, NDMD. As always, subscribe, like, follow, comment, all that good stuff, and we'll see you in the next one.